शुरू कर दे. Hi students, welcome back. I hope you can all see me, and there was some chota mota glitch which keeps happening here and there. So some problems with the files. So we are going to discuss about obstetric hemorrhage now, and obstetric hemorrhage is that major reason because of which women die in our country. Yes. Maternal mortality rate. If you know the maternal mortality rate, the latest one which the PSM people tell us is 88 women per 100,000, which is the standard way of saying that. Till last year it was 97. Before that before 93. Before that it was 97. Then it was 113 before that. In fact, when I was in my MBBS, I was doing my internship. I remember around that time it was something like uh, 556. I'm talking about my internship 1994, 95. And that time it was something like 556 women used to die out of 100,000. So we are getting better, but the target is to reduce it less than 70. Now we can reduce Hi guys, good evening, welcome again. And I don't know, today the systems are testing all of us. This network comes to you through a lot of people across the country. There are studios, and then there are monitoring centers, and then there's of course YouTube. So apologies for this almost half an hour of a delay, and we'll get back to work immediately, right, guys? So we are talking about obstetric hemorrhage. Just in case you missed out on the beginning part, so we are talking about obstetric hemorrhage, and obstetric hemorrhage is the cause of maternal mortality in our country. Maternal mortality in our country is presently 88 per 100,000 women. And this maternal mortality is basically because of bleeding, and that can be abortion related bleeding, and it can be about antepartum hemorrhage and postpartum hemorrhage. But remember, bleeding because of postpartum hemorrhage is the most common cause of mothers dying in our country. And we have always seen that if we try to get women to deliver in the hospitals, then we can reduce this maternal mortality. When I was an intern, I remember 94-95, that time the maternal mortality was 556 per 100,000. Now it is 88. So yes, obstetricians like us are working very hard, isn't it? We're trying to reduce the maternal mortality, but we'll not be the happiest till we get it down to something like less than 70. That is what is the goal, sustainable goal, that like we keep saying, that is the sustainable goal. If it comes to that, we'll be the happiest. But anyway, let's see if it can come down to less than 10, that will be the better one, because internationally women don't die because of PPH so much, so or any other obstetric hemorrhage. So women dying in pregnancy, maternal mortality is right now 88. We wanted to bring it down to less than 70. Internationally, the rate is only 10. That's what I was trying to say. Okay, is this going fine? I just wanted to confirm before we get into the next slide. Yeah. So it's going fine. So when we're talking about the bleeding obstetric hemorrhage, we are going to discuss mostly about PPH today, but we'll also tell you the causes. Abortion related bleeding can cause a woman to die. While a woman has had an abortion, let's say septic abortion, she can die because of that, and she can bleed because of an abortion. And then they can be bleeding because of antepartum hemorrhage, which is of course known as the placenta previa and the vasa previa and the Abruptio placentae. So that can also cause a woman to have severe obstetric hemorrhage. And then the postpartum hemorrhage. Postpartum hemorrhage, HAGE, I'm writing here. It is the most common cause of maternal mortality in our country. Now, when we're talking about obstetric hemorrhage, these are the causes of the obstetric hemorrhage. Let's deal with postpartum hemorrhage first. Now, postpartum hemorrhage, the incidence is 5% of all the deliveries, and significant bleeding is more than 1000 ml. Significant bleeding is more than 1000 ml after delivery from any part of the genital tract. Please do not get confused. Some of you are final year MBBS students here. You must understand that any part of the genital tract, if a woman is bleeding from the uterus after delivery, we know it is atonic PPH. So do not get confused. Most common cause of PPH, obstetric hemorrhage, is PPH. Then most common cause of that PPH is atonic PPH, that is the uterus is loose. But if the uterus is ruptured, at the cervix there's a laceration, the vagina has a laceration, the vulva there's a hematoma. All of these are also causes of women having bleeding. So postpartum hemorrhage is bleeding from any part of the genital tract. Okay, significant bleeding from the uterus, correct, but from even the cervix if it is torn, vagina if it is torn. I'll be telling you more about this. So yes, any part. See, PPH will happen, let's say the placenta was attached here and the placenta is removed, she bleeds from here. But if the cervix is lacerated, if the vagina is lacerated, any part, if it is bleeding, then that is what is called a PPH. So traditionally the definitions are 500 ml of blood loss in normal delivery, 1000 ml of blood loss in cesarean section. These are not outdated yet, all right, please, these are still important definitions. And significant blood loss, I told you, is 1000 ml. It is 1000 ml. Please remember, in your exams they'll keep asking you that how much bleeding is PPH. So 500 in normal, 1000 in cesarean, but what we now use a term is a significant bleeding. Now what is mild PPH? Bleeding 500 to 1000 ml, moderate PPH is 1000 to 2000 ml, and severe PPH is more than 2000 ml, right? What is massive obstetric hemorrhage? That is blood loss of more than 2500 ml of blood loss, which will drop the hemoglobin by 4 gram% and at least 4 units of packed red blood cells if 4 bottles of blood is required to resuscitate this woman. That is what is known as a massive obstetric hemorrhage. So these are the definitions they keep asking you in the exam. PPH is one topic. Do not, I'm telling you, if you are in your final MBBS exam, do not go for the obstetric exam if not read PPH topic. All right. So that's why please remember the screen well. And if you know this screen, I'm very sure that your discussion will start only once you know this in your PPH discussion, the table viva especially. Right. So types of PPH: primary PPH and secondary PPH. Primary PPH is the within 24 hours of delivery. Within 24 hours of delivery, and it is most commonly because of the atonic PPH. And you should know this much straight away, that the drug of choice, whatever you know, I'm going to tell you a lot of details, but the drug of choice is oxytocin. I'm going to finish off the question which is coming in your table viva. This is what you have to know immediately. Atonic PPH within the first 24 hours, and that is what is the primary PPH, and this is what is coming in exam. This you cannot afford not to know, this lines. Drug of choice is oxytocin. Now secondary PPH is after 24 hours until 12 weeks of delivery. So that is due to the retained bits. It is due to the retained bits of placenta. So when there are retained bits of placenta, they get infected and cause bleeding. We are not talking about the secondary PPH in great detail today. I want you final year MBBS students to know about the primary PPH properly. Primary PPH, it is because of the atonic uterus, and that is within the first 24 hours. Most commonly it is in the first 1 hour. Most commonly it is in the first 1 hour. But yes, within the first 24 hours is your definition. Secondary PPH is because of retained bits. So yes, this secondary PPH, I just thought I'll tell you a little bit more. Whenever a woman delivers, see, a woman has delivered and I have held the placenta in my hand. So I don't examine it like this. I put it on the back of my hand. This also they'll ask you if you've gone to the labor rooms or not. So as final years, you should be seeing deliveries, and after delivery, you should see that the resident or the consultant has taken out the placenta and he puts it on the back of his hand, and then that placenta is seen. Because if you keep it on the back of your hands are pronated like this. Why? If you see them on the back of the hand, because the uterus is like this, so the placenta should be examined in the way it was attached in the uterus, like the dome of the uterus. So you keep the placenta on the back of your hand and you see if there is some deficiency here. Look, there is a small deficiency here in this placenta, because there was a retained bit in one of my patients, and we examined, we saw this deficiency and we took it out, and there was no secondary PPH. So secondary PPH, I'm just trying to inform you what it is. We are going to discuss primary PPH mostly, which is atonic, but always examine the placenta. See, there was a deficiency here, right? So what is coming back to PPH? Primary PPH is what we're going to discuss. So what is the concept of uterine contraction? So if you see the placenta, it is attached to the uterus like this, and what are you going to do? You're going to hold the uterus with a hand like this on the fundus and hold the cord like this. Gentle traction and counter traction. See, this is the method of delivering the placenta. Control cord traction. This is known as control cord traction. So when you gently pull and see if it is coming out, you give a counter traction here. Control cord traction. So with that, the placenta will come out immediately. I'm sorry, will come out ultimately. I'm sorry, immediately is not the right way to deliver. It'll come out ultimately, and when it comes out, the base of the placenta, this is the place which is going to bleed like crazy. She's going to bleed almost 800 ml per minute. That's what is the volume of the uterus. 800 ml per minute is the flow coming to the uterus. So that's why you want the uterus to contract. Contraction should be immediate. Yes, it should be immediate contraction. So when the uterus contracts, see, look at this muscle here. Look at this muscle here. Now look at the muscle here. It is contracted. So contraction of the uterus is paramount. This is paramount. So when the uterus contracts, see here, when the uterus contracts, this contraction of the uterus, look at these blood vessels, look at this blood vessel here, mota, big blood vessels, bleeding is happening, uterus contracts. So when the uterus contracts, can you see, when the uterus contracts, these muscles of the uterus, they are crisscross. See the muscles, this pen of mine is like the blood vessel, and there are these contractions of the crisscross muscles. So when they contract like this, they're going to squeeze the blood vessels which are bleeding. So contraction of the uterus is paramount for the management of PPH. Uterus should contract, and that's why you do the massaging of the uterus. That's why massaging is part of management of PPH, prevention and management both. So remember, if you're having any doubt about uterine massage, see this picture and you'll never have a doubt. If the uterus doesn't contract, bleeding happens. So we try to prevent by doing massaging, and if she's bleeding, we try to treat by massaging, because contraction is paramount. So I've taken at least 7 times repetition of this topic right now here. The uterus should contract. So when the uterus contracts, the crisscross muscles, okay, this is the word, the crisscross muscles of the uterus, they work like the living ligatures. They are the live ligatures of the blood vessels, the live ligatures, okay. So when the uterus contracts, this blood vessels will be squeezed by the contracting muscles. They behave like ligatures of these arteries. Contraction, bleeding stops. That's the best management of prevention and treatment of PPH. So normally uterine contraction happens like this, and this will prevent the PPH. Now, if this doesn't happen properly, what can go wrong? Then they can be atonic uterus, and that is the cause of PPH. 80% atonic uterus can be because of a large baby, a big uterus because of big baby, large amount of liquor, polyhydramnios, twin gestation, uterus is so big. So it comes back after delivery, the uterus will come to the contracted size, it will take long time. So that is why they can be atonicity. Infections can cause atonicity, and prolonged labor can cause atonicity. Then injuries can cause. Uterine rupture can happen because of, let's say, previous cesarean, or it can be in a multigravidae rupture can happen. Laceration of cervix, laceration of vaginal perineal, laceration, again lacerations, I'm talking injuries, vaginal perineal lacerations, operative deliveries, uterine inversion, all these are known as the traumas which can cause PPH. So bleeding from any part of the genital tract, remember I told you that, don't forget that part, okay. So atonic uterus, most common cause. Then coagulopathies, von Willebrand's disease, idiopathic thrombocytopenic purpura, retained tissues, like I told you, retained tissues will cause the secondary PPH. So these are the 4 T's: abnormal tone, then trauma, T for trauma, then thrombin deficiency, coagulation, thrombin deficiency, retained tissues, again T. So 4 T's of PPH. So 4 T's you should always be able, this is what these examiners like to hear, whether you're writing your theory paper also. 4 T's kya hai? Tone, trauma, thrombin, tissue. So tone, trauma, thrombin, tissue, these are the 4 causes, and the main cause is the atonic uterus. So yes, management, always prevention is better than cure. Oxytocin is the drug of choice for prevention, and prophylactic oxytocin is given. When do you give it? At the delivery of the anterior shoulder of the baby. Now this is what we're going to discuss in detail. Moment the woman is in labor and the woman's baby has not totally delivered. Look, baby delivers, plaster delivers, PPH happens, you give drugs, PPH stops. Correct. That is management of PPH. But we are faster working people. We will do active management. We will start managing the PPH before it happens. We are going to do prevention. We are going to start acting from the time when the head of the baby comes out, and I know now next the shoulders will come out. So when the head comes out, you hold the head and give a downward tug to the shoulder and the anterior shoulder comes out. So this is how you do the delivery, isn't it? Head comes out, anterior shoulder comes out. Moment this anterior shoulder comes out, why do I say I give the oxytocin at this time? Drug of choice is oxytocin, you give it at the time of anterior shoulder. Why do we keep saying that? This is what they ask in the exams. Why was students? Very important question. Broadest part of the baby. See, the broadest part of a fetal small baby, okay, the fetus, the broadest part is the biparietal diameter. See the biparietal diameter. So the broadest part of the baby is the biparietal diameter. Moment the head of the baby comes out, then the next broadest are the shoulders. Moment the shoulders come out, I know, okay, delivery will complete. Iska delivery ho jayega. Why? Because the head has come out and that is the broadest part, delivery will complete. But sometimes a mother is having a big baby, let's say in a diabetic mother. So big baby, the shoulders are also very big. So shoulders may get stuck. So if the head comes out and the shoulder comes out, this delivery will complete. हो ही नहीं सकता कि delivery नहीं होगी. This is for sure now. So that's why we wait for the delivery of the anterior shoulder. Moment the anterior shoulder comes out, we know that the delivery is going to complete. Then you give the oxytocin. So when you give the oxytocin after the delivery of the anterior shoulder, head comes out. Intern, get ready, okay? Head comes out. Intern, ready, hai na? Okay. I'm holding the head of the baby. Anterior shoulder comes out. Intern, oxytocin de de. Intern gives the oxytocin intramuscularly now. Moment the anterior shoulder comes out. Now the posterior shoulder will come out. Then the baby will be, you will pull out the baby slowly, and then you will hold the baby down from the level of the mother for almost a minute. Delayed contraction so that you get hemoglobin increase for the baby by 1 gram. And after that, you will do the control contraction. Delivery of the placenta is going to take almost something like 5-10 minutes. At the time the placenta delivers, the peak action of oxytocin is achieved, and that's why the uterus immediately contracts. So you do active management of third stage of labor. That is, you will give oxytocin at the delivery of the anterior shoulder. So that is what I'm going to teach you here. I've already given you a big description of what I'm going to teach you. AMTSL, active management of third stage of labor. This is your long question, this is your short question, and this is your viva question. It is coming in your exam. May come? No. It is coming. PPH is coming in your exams. Okay. So yes, active management of third stage of labor, 70% we will reduce the incidence of PPH. So the head comes out, the shoulder is stuck here. You take the head down, pull the head down, the shoulder comes out, and then you give the oxytocin. So oxytocin we are giving is something like this is the steps of active management. Oxytocin, the first step, and you give 10 international units intramuscularly. Can give it IV also, slow IV always, okay, never like a bolus. You have to dilute and give. That's why you give it IM, undiluted you can give. Oxytocin at the delivery of the anterior shoulder. That I already told you. Let's move on. The second is the delayed cord clamping. You have to wait for at least 60 seconds. More than 60 seconds you have to wait, so that it increases the hemoglobin by 1 gram %. Now, contraindication to this drug of choice, the delayed cord clamping rather, is the baby is sick. You want to resuscitate the baby. Baby is having some hypoxia. Then you cannot hold the baby for 1 minute like that. You have to give the baby to the pediatrician, isn't it? The neonatologist will be there. Or there is maternal instability. Mother is sick and we cannot wait with the baby hanging from the mother. Or there are placental problems like there's a vasa previa which had bled and now the baby has come out. Or there is a problem that there was a case of an abruption, or there was a retained placenta. There is a problem that the placenta might be bleeding because of the abnormal types of placenta. So that's why you don't want to wait. So specific conditions where you have to defer, specific conditions where you have to avoid doing delayed cord clamping are the conditions like fetal hydrops, twin-to-twin transmission syndrome where the baby is sick, and HIV and HBs positive mother, because perinatal transmission can happen around the time of delivery. So all these conditions will avoid, and a lot of people say in RH negative also you should avoid delayed cord clamping. But yes, it's a little debatable. A lot of people are refuting that. Whichever medical college you are in, please speak to your teachers whether they want you to say RH negative or not, because we traditionally used to say that RH negative patients, if you wait longer, more blood from the baby can go into the mother. So just confirm about this in your hospitals what they're trying to tell you. Okay. So control contraction. This is the method of delivery. I told you that earlier. You give a counter traction in gentle tug on the cord and counter traction. That's how you remove the placenta. Now there are the 3 steps I told you. One, I told you about the oxytocin. Second is the delayed cord clamping. Third is the control cord traction. And the fourth is the uterine massage. Fourth is the uterine massage. All right. So uterine massage, extremely important. Gentle uterine massage. We do a gentle uterine massage, and that promotes smooth muscle contraction. And please, uterine massage is done. I'm not getting into controversies right now because you're still in MBBS. There's a lot of talk about not doing uterine massage, and there's a lot of talk about you telling the mother to put the hand on her own abdomen and feeling for the uterus, self-assessment of uterine tone. All of that is not done, guys. Uterine massage has to be done. You are in your final year, please go into the labor room and meet your consultant. And he or she will tell you whether uterine massage has to be done or not. And if you say that uterine massage is not done because WHO is saying that, he'll get a little angry with you, because uterine massage is done. It is written in the front of your labor room, please do uterine massage. Okay. So WHO says a lot of things. We regard WHO with highest respect, but till their recommendations are implemented by the hospital, that is the Ministry of Health and Family Welfare should implement it into our government hospitals, private hospitals. Till it is not implemented, we are not going to start following what is written on the WHO's website, or it is coming in the Center for Disease Control, or it is coming from the American College or Royal College. So you are in your MBBS, learn your core basics properly, please do uterine massage. So yes, I'm trying to show you, this is that picture. I'm sure most of you in your hospitals would have seen this active management third stage of labor. This poster is there in front of all government hospitals. If the hospital is a private hospital, they'll have the same components written with their own. I went to Manipal hospital, I saw that. I went to MAMC, I saw this, but they had their own method of writing the same 3 things. Okay, I'm taking names because I hope they don't object, but it is there in all the hospitals. It is there in all the hospitals. All right. So injection oxytocin, control cord traction, and uterine massage to keep the uterus contracted. These are the steps, and this is there written in most of the hospitals in the country, even in the Hindi language, the same thing. All right. Give oxytocin, then control cord traction, and then uterine massage. This is given by the Government of India. You have to know these steps, okay, if you're passing your exams. Then this one, I was just trying to show you this poster. If you magnify it, this part of the poster I want you to see. This is what is written here. It is written for use in medical colleges and district hospitals and first response units. Okay, it is written as clear as that. So that's why it comes into exams also. Okay, so there is no way that you will you will avoid this uterine massage. Chalo. Let's move on. And what is not very important in the active management of third stage of labor is the delayed cord clamping or the early cord clamping. Yes, if you read Williams Obstetrics, it actually says do early cord clamping. There's nothing called delayed cord clamping. We in India and developing countries, we do delayed cord clamping to increase the hemoglobin. So if we do delayed cord clamping or early cord clamping, it does not change the incidence of PPH. So treatment of PPH is treatment of shock. Now, we were talking about the prevention of PPH. So prevention of PPH, let's go back again. A woman is delivering. We have no problem with the lady's medical condition, and we do active management of third stage of labor. You give her oxytocin at delivery of the anterior shoulder. Once the baby comes out, we do control cord traction. We do delayed cord clamping. Delayed cord clamping and then control cord traction, and after that we do the uterine massage. Those are the steps of the active management of third stage of labor. That's what I told you. Now the patient has delivered and everything was fine. Patient goes home. We are talking about a situation where there is PPH. How do you manage PPH? PPH has happened. Now we're in that discussion. Active management third stage of labor is a very important set of objectives which you should be fulfilling before you do a delivery, and that comes into exams. But how do you manage PPH which has happened? That is also extremely important. So how do you manage the PPH? PPH has happened. There's a patient who's delivered, she's bleeding profusely. What do you do? The treatment of shock, first of all, high concentration of oxytocin, 15 liters per minute you give, monitor the vitals, and then give central lines, Foley's catheter to measure the output, record input-output charting, arrange for blood products. She should be kept warm in a flat position and send blood for cross-matching. These are the steps you have to manage a patient with any shock, any emergency. Keep that going and give 3.5 liters of warm crystalloid Hartmann solution, which is also known as the Ringer lactate. You have to give, or give colloids, like you can give dextran. You can give dextran as a volume expander, or you can give starch. We call it hexa starch. So you just write starch for the time being, hexa starch. Hydroxyethyl starch is the name. So starch or dextran, that will be a colloid. It will hold back fluids from getting lost, so they'll increase their volume expanders. So you can give IV fluids, you can give colloids, crystalloids and colloids. Then we have to give management of PPH. We can also give recombinant factor, activated 7A factor, 90 micrograms per kg body weight in 3 to 5 minutes in a IV infusion. And compatible blood is given as fast as possible, as soon as possible. But if compatible blood is asked for, let's say the woman is A positive and you're asking for A positive blood, the blood bank is going to do the cross match over 45 minutes at least, fastest people. So 45 minutes to 1 hour will take for the cross match blood to come. By that time the patient may die. So O negative blood, we obstetricians are the biggest consumers of the O negative blood. Yes, we keep doing that so many times. So O negative blood you give for the time being. You can just give O negative blood which is tested for serology and kept in the blood bank. And we increase the fibrinogen by giving blood products. That is, we can give FFP. We have to keep the fibrin level to at least 100 milligrams per deciliter. Generally it is 300 in non-pregnant women and 450 in pregnant women. That is the level of fibrinogen. Now this is fibrinogen, is that distinction question which they'll ask you. PPH management, drug of choice for prevention and treatment is oxytocin. You'll pass your exam, correct. But if you want good marks, they'll ask you how much is the fibrinogen we want to be. The fibrinogen should be at least more than 100 milligrams per deciliter in the patient. She's bleeding a lot, she's losing blood, she's losing clotting factors. So we give products to increase the fibrinogen level to at least 100 milligrams per deciliter. That's your target, at least 100 hona chahiye. So normal is 450 in pregnancy, but you should get at least 100. So 30 ml per kg of FFP you can give, or you can give 3 ml per kg of cryoprecipitate. Cryoprecipitate, these are the blood products. You must read about the blood component therapy. Cryoprecipitate will increase the FFP much, will increase the fibrinogen much in much lesser volume. Okay, so it's given 3 ml per kg of body weight. And cryoprecipitate approximately contains 10 times the concentration of fibrinogen as much is present in FFP. So 10 times the concentration of FFP. So therapeutic goals in PPH, what are you trying to see? I was trying to tell you, you want to keep the fibrinogen to the level of at least 100. So that is here. Fibrinogen should be more than 100 milligrams of deciliter. That's the target. The woman who is bleeding too much, the HB should be more than 8 grams. If she's bled a lot, she's gone to 5 grams or 6 grams, she's gone down. You must increase it to at least 8 grams. And prothrombin time should be less than 1.5 times of normal. So normal prothrombin time, understand this, this is a little complicated. Some of you are watching this because you're writing the NEET exam also. So you please understand, normal prothrombin time is something like 12 seconds. Woman is bleeding too much, she's having PPH, so prothrombin time will increase because she's bled a lot, the clotting factors are lost. And the prothrombin time may increase to 25-30 seconds and she'll bleed a lot. So you're giving these blood products, so you have to keep the prothrombin time to 1.5 times and lesser. So let me explain. Normal is, let's say, 12 seconds. 1.5, 12 seconds. 1.5 times of that is 18 seconds. So we must try to keep it less than 18 seconds. Keep the prothrombin time less than 18 seconds. So that is what is a good achievement. She's bleeding a lot, give her blood products, and the normal prothrombin time is 12, but she's bled a lot, it could be going up to 30 seconds. So you reduce it to less than 18 seconds, less than 1.5 times of normal. Similarly, activated partial thromboplastin time less than 1.5 times of normal, and platelet count should be more than 75,000 per microliters. Normal platelet, you know, is 3.5 to 4 lakhs, isn't it? So at least more than 75,000 it should be. These are the goals which you should have. Distinction stuff, guys, all you final year MBBS students. This is what will give you good marks. When you write PPH, write a box. You should write abstract when you write in your, don't write long stories. Aim to keep these goals. And how do you achieve these goals? That's what I'm teaching you. All right. So treatment of PPH. Now she's bleeding a lot. The drug of choice is oxytocin, 10 to 20 units. We give it in a drip. We give it in an IV infusion. We never give it a IV bolus of 20 units. She can go into oxytocin overload. So give it in a slow infusion. Okay. And it can cause serious hypotension. This oxytocin, the too much use of oxytocin, and cardiac arrhythmias can develop. So we give it only around 10 to 20 units. Maximum, most people say 40 international units use of oxytocin is more than enough. If it is not working, come to the next drug. So carbetocin is the next good drug. It is a synthetic analog of oxytocin. Now do not get confused with carbetocin. Don't say carbetocin and carboprost are the same. You get confused with these two drugs. Carbetocin, oxytocin. So similarly sounding drugs. So these are actually similar drugs. Oxytocin is a naturally occurring drug and carbetocin is a synthetic analog of oxytocin, only it is better. So a lot of people are not giving oxytocin, they are giving carbetocin these days. So carbetocin, I am sure in your hospitals they are giving that. 100 micrograms IV in 1 ml over 1 minute. That's how we give the carbetocin, and this action lasts for around 1 hour. That's why it's a better drug. Oxytocin action lasts for 15 minutes. Uterus is contracted for 15 minutes and after that it stays contracted. But if a woman is having a flabby uterus, then a uterus which is tired because of a prolonged labor or an infected uterus, so then it's going to become loose after 15 minutes if you give oxytocin. So longer sustained contraction with carbetocin. That's why this is a better drug. But so far, drug of choice for prevention treatment is oxytocin. Don't change that answer. They ask you extra questions, you must say carbetocin. Methylergometrine, my favorite drug. If any one of you final MBBS students, MCI students, PG students watching this, if you are becoming a gynecologist, then please rely on methylergometrine. This drug is not a drug, it is magic. Methylergometrine just contracts the uterus in as fast as 90 seconds if you give it slow IV, obviously. So peak action in 90 seconds. Did I say minutes by mistake? 90 seconds it takes. It acts like magic. Can also be given IM. Yes, both methods are given, but we give it slow, diluted and slow IV is given. Methylergometrine, it works fast, but the problem is if it suddenly contracts the uterus, so all the blood in the uterus goes into the circulation. So that can be bad for heart diseases and hypertension patients, and also in RH isomnization. So contraindication to methylergometrine you should know, because if the uterus suddenly contracts, more blood from the baby can go into the mother. So these are the contraindications, and before the second twin also you should not be giving any oxytocin, whether it is methylergometrine or oxytocin. You should confirm that there is no other baby in the uterus. Okay. Then carboprost. Now this is that go-to drug. If nothing works, then carboprost will work. This is the go-to drug. That is, if you give an oxytocin, carboprost, methylergometrine, you can also give misoprostol before that. Misoprostol, I don't know where I missed it, but misoprostol also given as a rectal tablet. That is also a good drug. But if nothing works, the best drug we give is the carboprost. So carboprost is given intramuscular only, never given IV, cause sudden hypertension, and the dose of carboprost is 250 micrograms intramuscularly. IV it causes sudden hypertension. Okay, can be given into the uterine muscle also, intramyometrial. And yes, like I said, when no drug is working, this will work. Okay, tranexamic acid, antifibrinolytic, any bleeding condition, right from bleeding tonsils to intracerebral bleeding to bleeding in surgical bleeding while we're doing some surgery, or PPH. Everywhere, any bleeding, nowadays tranexamic acid is part of the management. I'm not saying it is the drug of choice. I'm not saying this is the last line of defense. It is one of the things which is given. Drug of choice, oxytocin, and nothing works, that drug is carboprost. Okay, chalo. If nothing works in the drugs, you tried all the drugs, then you come to surgical methods. So intervention, the first method, this has become a hotshot MCQ question. First surgical method, basically you're not doing any surgery, first intervention they say. First surgical treatment, if nothing works, is the balloon tamponade. So it is called the Bakri's balloon, and you distend this by 500 ml. See, this is the Bakri's balloon, and this is put into the uterus, and this is distended, and it compresses the bleeding point. So we have put that balloon here inside, distended by 500 ml of normal saline, and that is going to cause the compression of the bleeding points. So Bakri's balloon, they'll give this. This will be your instrument viva when you're doing your MBBS exams. Okay, miss nahi karna isko. Then surgical methods next is the brace suture known as the B-Lynch suture. open the abdomen, deliver the uterus out and tie some ropes on the uterus. B-Lynch hemostatic suture. If the balloon is not working, then you have to next open the abdomen and try to do something with the uterus, because next you're going to do a hysterectomy, isn't it? So to prevent the hysterectomy, you try to contract the uterus physically by force, tie two ropes on the uterus. So how do you tie the ropes? Like this, you go through the uterus from the you have to make an incision on the uterus and do this. There are some other type of sutures also. We'll avoid the discussion now, but you should know B-Lynch suture, and you will tie up the uterus. See those two ropes you tie, and that's what it looks like. If you see where I put a B-Lynch suture here, can you see these two on the uterus? This is the B-Lynch hemostatic suture, and that will cause the uterus to forcibly contract if the drugs are not working, and then that the bleeding will reduce. But the next thing is, if these don't work, then you have to start doing the ligations of the arteries. So first artery which you ligate is the uterine artery, and next you ligate the ovarian artery, and if that doesn't work, then you come to the ligation of internal iliac artery. So internal iliac, if you see, this is the aorta is here somewhere. This is the common iliac. Okay, so this is the left common iliac, right common iliac. In this common iliac, you have the internal iliac and the external iliac. So when you're ligating the internal iliac, why we are talking about the internal iliac artery? Because the uterine artery is a branch of the internal iliac artery. So this ligation is a hot shot topic as a short note in MBBS and a regular question in your any entrance exam. Internal iliac artery ligation. First, they'll ask you what are the branches of the internal iliac artery. So, common iliac, internal iliac. Internal iliac has an antedivision and a posterior division. Antedivision has these. See, antedivision has 7-8 branches. Okay, and uterine is the main artery which you have to remember. You must remember all of them: superior vesicle, inferior vesicle. Yes, you can mug it up, but एक basic understanding क्या है? All the organs in the pelvis are supplied by the internal iliac artery, the major artery of the pelvis. ये याद रखो. Ultimately, when they ask you the branches, remember the organs, remember the muscles, and you just will not forget. Internal iliac artery, if you start mugging up things, then you will keep mnemonics in your mind. But you mug up that, what you have to remember, all the organs in the pelvis are supplied by the internal iliac artery. That's why in the pelvis, below the umbilicus, okay, below the stomach rather, below the stomach area, hypogastrium, epigastrium, periumbilical, and below the stomach, hypogastrium. So the hypogastric artery, yes, internal iliac is actually known as the hypogastric artery, and that's where you keep getting confused in nomenclature. Hypogastric artery or internal iliac artery is the major branch of the pelvis. So major branch of the pelvis, what are the divisions? Antedivision and the posterior division. Antedivision supplies the bladder, superior vesicle and inferior vesicle, supplies the uterus, uterine artery, goes through the obturator foramen to supply the muscles, and then rectal artery, pudendal artery. I think you can't see that so well, but the pudendal artery also, the perineal blood supply, also pudendal artery is also the part of antedivision. Posterior division is superior gluteal artery, iliolumbar artery, and lateral sacral. So why I go in this order? Because I want to give you this mnemonic: superior gluteal, iliolumbar, lateral sacral. So I used to remember as short gills. Fishes have gills, short gills. Or nowadays, the current heartthrob of the country, Shubman gills. You can remember that way also. But Shubman gills you have to remember. So superior gluteal, iliolumbar, lateral sacral. All right. So these are the branches of the posterior division. Now, what happens when these exam questions come? So most people remember the posterior division arteries because there are only 3. So posterior division are superior gluteal, iliolumbar, lateral sacral. So by exclusion, you can answer all of the following are the branches of the antedivision except. All of the following are the posterior division branches except. Like that questions we keep coming in exams. Remember this one, posterior division, then you can by default give that answer. But like I said, remember that all the organs in the pelvis are supplied by the internal artery, and the posterior division are these 3. Rest whatever organs are there, they are supplied by the antedivision. Chalo, that is the help I'm trying to give you to remember. But once you understand this, where are we ligating the internal iliac artery? That is a PG entrance question, and also maybe your distinction question. Internal iliac artery, everybody knows. Which part of the internal iliac artery are you ligating? First of all, we are worried about the uterine artery. So we are ligating only the anterior division. We are ligating only this. We are not ligating the posterior division. So internal iliac artery is not ligated here. No, 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 no. We are not ligating it there. So please remember, I'll take out all the clutter from this screen. Wait. The internal iliac artery is not ligated here. It is ligated in the anterior division. Posterior division is not ligated because we are trying to reduce the blood supply of uterus. So internal iliac artery, the principle is to ligate the anterior division. First principle, anterior division only is ligated, and it is a snug ligature, a comfortable ligature, not a ligature which is going to squeeze the hell out of that artery. We are not going to squeeze it close. No, it is not tight to stop the blood supply. No, man. Snug ligature to reduce the flow. It is to reduce the flow, not to stop the flow. So when there's reduced flow going to the uterus, and that reduced flow in the uterus which is bleeding, reduced flow will promote thrombosis. The principle is not to stop, it is to reduce the flow. Basically, they say the pulse pressure of this uterine artery, because this ligature behind, the pulse pressure of this uterine artery changes from an artery to that of a vein. So that is what is the principle, reduce the flow. All right, guys. So yes, branches of the anterior division, posterior division, I have written that for you now. You must remember them. And I've given the mnemonic for this one. And the principle is a snug ligature will reduce the pulse pressure, and pressure of the artery reducing becomes equal to the vein, and sluggish flow will induce thrombosis. Here, can you see thrombosis is happening in these blood vessels? So that's what I told you. We've written that in notes already, right? So no worries about writing your notes. At least if nothing works, then you have to do a hysterectomy. Then a hysterectomy is the last option for the management of PPH, right? Secondary PPH is the PPH after the first 24 hours to up to 12 weeks, and that is because the retained bits. So that is, retained bits can be removed only with a curettage. So treatment is curettage. Secondary PPH treatment is curettage. Primary PPH, please don't say primary PPH is curettage. That means you not listened in the class properly. Okay, I'm not trying to get tough on you guys, but please, secondary PPH is unlikely to come in your MBBS exam at least. Primary PPH nahi pata to secondary to they'll not bother. Primary PPH, if you know, then you classify it to secondary PPH, and then you know the management of both, then you get 9 out of 10 or 8 out of 10 in your theory marks. All right. If you say primary PPH management properly, you'll get 6 out of 10. But if you know secondary PPH, and that is your curettage is the treatment, you're increasing your chances to get better marks. So let's get into the other problems of bleeding, and that is placenta previa. We are talking about obstetric hemorrhage, and placenta previa and abruptio placentae. These are bleeding before delivery, antepartum hemorrhage. So APH definition is bleeding before delivery, antepartum hemorrhage. So that can be because of placenta previa. This is, two things you should know. Woman comes to you at term, painless bleeding, placenta previa. Painful bleeding, abruptio placentae. These are your like engraved into your genome kind of, if I take out your blood and I do a karyotype, and on your chromosome 6 short arm implanted information milna chahiye mujhe. Yes, painless bleeding at term, placenta previa. Painful bleeding at term, abruption, so that it is transmitted to the next 7 generations of you. That's how it is. You have to know painless bleeding at term, placenta previa, painful bleeding, abruption. ये मतलब set information है OBS की, ठीक है. Let's move on. So placenta previa is 1 in 300 to 400 pregnancies at term. इसका मतलब क्या हुआ? What I'm trying to say here, that the woman is having a placenta which is covering the os, correct? But that covering of the os, if I try to show you like this, see here, I'll try to show you like this. See, yeah, okay, look here guys. I'm trying to show you my hand as the uterus, okay. My arms are the uterus, this is the cervix. What I'm trying to show you here, my phone is like a placenta. In the initial days of pregnancy, look here, the placenta is covering the os, that is placenta previa. Now what happens later? Later means at term, this cervix will get effaced and will get dilated. See, cervix get effaced and dilated. Now when the cervix gets effaced, because it's going to deliver at term, see, can you see the placenta is moved away from the os? Placenta is not covering the os anymore. Understand this, guys. Placenta is covering the os. Can you see it is covering the internal os? That is what is placenta previa. But with the effacement, the placenta moves away. So what is placenta previa in the initial few months of pregnancy may not stay as placenta previa later half of pregnancy. That is the funda of placental migration. We are mentioning that again later on. So 1 in 300 to 400 pregnancies at term is placenta previa. In initial pregnancies, ultrasound, so many, even today when I was doing ultrasound, today was Saturday, yes, I had something like 11 cases of early pregnancy ultrasound. I am on the head of the infertility unit, and when women conceive the first few months, we keep them with us. Then they go to the obstetrics unit. And when we have the early ultrasound, out of I think 11 early ultrasounds today I did, I think 4 had placentas covering the os. Yes, we didn't even tell them that you have a placenta previa. It's only 9 weeks, 10 weeks. The placenta is just starting to form properly. It is there on the internal os. I know it is the uterus is going to become bigger and later she is going to efface. So I'm not going to throw an alarm that you have placenta previa, you're going to bleed. No. Even placenta previas don't bleed every time. What did I say? Oh, what did I say? Even placenta previas don't bleed every time. Yes. Understand that placenta previa is placenta covering the os. But don't think that all placenta previas will definitely bleed and she'll come only in the emergency and she's going to die. Ore yaar, placenta previas may bleed sometimes. That's all. And you should be prepared for it. You should have always done an ultrasound of a lady and tell these women who have a placenta covering the os that stay within 3 kilometers of the hospital. If you have an emergency, well, if you're in Delhi, then you should say you should live in front of the hospital. 3 kilometers also may take a time to come to the hospital. So you should be living in front of the hospital, next to the hospital, within I think 100 meters you should say. So if a patient bleeds, then it's a bleeding placenta previa, which can happen many times, but not always. Keep this fundas in your mind, guys. Theory padh ke bas ratta maar ke, if you go and attempt an exam, you will pass. But if you want to understand, then you will manage patients. Becoming doctors and managing patients as doctors, two different things. So understand. So placenta previa mostly doesn't bleed. It is there. Don't scare the patient first of all. Tell her that we'll keep doing ultrasounds. Later at term, we'll see if the placenta is still covering. Okay. So it happens more in multiparous women, twins and triplets, because there are 2 placentas or 3 placentas. So 2 placentas are up, 1 placenta is in the internal os. Can happen, isn't it? Previous cesarean, scar will predispose. Previous hysterotomy, scars will predispose for the placenta to get stuck in the lower segment. Myomectomy again, and dropping down theory of the embryo. That is, the embryo at the time of implantation, when the embryo came into the uterus from the fallopian tube, the embryo came and it dropped here and implanted. So ultimately the placenta was covering the os in this patient when the baby finally formed. So dropping down theory of the embryo. So classification of placenta previa, you have the partly covering the os and you have the totally covering the os. So partly covering the os, placenta is like this. Then totally covering the os, it's like this. And then low lying placenta, it is not covering the os, but it is within 2 centimeters. It is within 2 centimeters of the internal os. That is what is the low lying placenta. Okay, so partly covering, or we also call it the marginal placenta previa, and totally covering the os, or the completely covering the os. So this is the classification which is coming in the exam these days. We are not asking you type 1, type 2A, type 2B, type 3, type 4, all that is outdated classification. And I'm sure if you write this one, your teachers will give you all the marks which are required. This is what is the classification: partly covering, totally covering. Remember, The placenta which is in the initial months may change later because of the placental migration. I told you that already. I showed you with my hands. And then only presentation of placenta previa is painless bleeding PV. It is because the sharing of the sharing matlab udhar jana in Hindi. Udhar jata hai placenta. Sharing of the inelastic placenta may be associated with physical activity. Coitus can be predisposing. Digital examination by a gynecologist. Sometimes we don't know it's a case of placenta previa. We were careless. We have not seen the ultrasound, and we are doing a PV of a lady at term. With our finger, we can disrupt the placenta which is in the lower segment. Yes, it has happened with us also. We worked in government hospitals, and I was, somebody pulled my ears literally, and thanks to that doctor, that I became somewhat better. So yes, it does happen that we see a lot of patients in government hospitals. In JIPMA, we used to get 350, 400 patients in a day, and I have done these complications. And any surgeon standing here and telling you that he's never had a complication, he's not a surgeon. Okay, he's lying. Okay. So yes, we've had these cases. Patients have come and we have to see their ultrasound and then only do PVs at term. But there are so many patients and we have to finish the OPD and go to the ward and finish the admissions and then go to the labor room, and we are always in a hurry. We gynecologists, we tend to do mistakes sometimes when we are juniors. So yes, that's why you need senior residents who will be there to hold your ears. They become your best friends later in life. People listening to this, they'll know whom I'm talking about. Some of my best friends are now head of the departments in major hospitals, all my senior friends, and thanks to them, I'm standing in front of you and teaching. So right, so please do not do these mistakes of doing a digital examination if you've seen a placenta previa is there. Okay, then diagnosis of placenta previa can be done by ultrasound in a full bladder, which is Doppler assisted, which is a best method of doing the diagnosis of placenta previa. Now situation one, I'm telling you 3 situations of placenta previa. Placenta previa presenting bleeding at term 37 to 42 weeks. Please don't do PV examination. She's already bleeding. PV will cause more bleeding. So never do a PV examination. MCQ and solid, this Viva question for you. It may increase the bleeding, and manage with resuscitation plus cesarean section. So we'll just tell you the basics of this placenta previa and abruption for this class today. So placenta previa, cesarean section at term after resuscitation. Yes, situation 2, patient has come with placenta previa. See, placenta previa comes with bleeding at term. Situation 1, resuscitate, operate. Patient can bleed with placenta previa, but most of the time she doesn't bleed. She's sitting in the OPD, placenta previa at term. She's sitting in the OPD and waiting for a turn, and she comes and says, "Sir, आपने मुझे term पे बुलाया था. I'm 37 weeks. I see the ultrasound. Yeah, she's placenta previa. अरे intern यार, इसका एक बार ultrasound confirm करवा दे. Ultrasound करवा के, then you bring her. If it is still covering, we'll have to do cesarean, isn't it? Cannot deliver normally. But if it is moved away, we can do normal delivery. Can move away. Remember, I told you at term it can move away. So that's the management of placenta previa at term. So if it is at term and not bleeding, please, I've told you many times, the placenta previa does not always bleed. If it is not bleeding, then what do? You can do something called the ultrasound shows totally covering. I'll write that, totally covering still. If it is totally covering, you do a cesarean section. You can't do anything else. If it is totally covering, there's no way you can do a delivery. If it is showing partly covering, and people like me will still do the double setup examination, and this double setup examination is in the operation theater, and you have a labor room also in the hospital. You do it in the OT under mild anesthesia, mild sedation rather, with the preparations of a cesarean section. So the patient is at term, let's say 38, 39 weeks. The patient is taken to the OT. In the OT, I do a per vaginal examination, and when I do a PV, I see the placenta is still covering the os, and the head is very high. If it is still covering the os, then I will do a cesarean section there and then in the OT itself. But sometimes what happens, when I do a PV, I see the placenta has actually moved away. It is not covering the os. The head has come down and the placenta has moved away from the internal os. That's why the head will go down. If the placenta is covering the os, the engagement also doesn't happen. High floating head at term, placenta previa is one of the causes. So yes, if the head has gone inside, if it is moved away, if it has moved away, the placenta has moved away, then you send it to the labor room. Send it to the labor room and then do her normal delivery can be done. So yes, this is that you know INICT, PGI JIPMA entrance type of question. They keep asking you very occasionally, because double setup examination, there are not many proponents of that, but it is still mentioned in your Williams. So we are still teaching you double setup examination only when she is not bleeding, guys. When she is bleeding, please don't do PV. I already told you. What you should know as a MBBS student: Placenta Previa, bleeding, resuscitate, that is IV fluids, arrange for blood, and take her to the OT, do cesarean section. If it is not bleeding at term, I told you, this is the option management. It's all there in the app also, so don't miss out on this. Yes, guys, let's move on. Placenta Previa, bleeding at 32 weeks. Situation number 3. The lung is not mature. Lung is immature because the fetus is less than 32 weeks. So that's why you will give resuscitation, that is, she's bleeding. You'll rest, make the patient rest in a high risk ward, IV line, IV fluids, blood, etc., and give a sedation. Then steroids for fetal lung maturity. This is the resuscitation and steroids. What else you do? She is 34 weeks and before. Let's say 32, I have given you as an example. Let's say 32 weeks as an example. Anytime before 34 weeks, if they give you, this question will also come, lung is not mature. So what do? You give steroids for the lung maturity. How long can you wait? You know what happens? When a patient bleeds with placenta previa, first episode will stop in 90% of patients and nothing else has to be done. See, if the patient comes to you with bleeding at term, you don't have to wait for anything. Term means 37 to 42. If she bleeds, take the baby out. Anyway, placenta previa is bleeding, there's nothing else to be done. You cannot do normal delivery. You have to do cesarean and end of discussion. Patient is bleeding before 32 weeks, before 34 weeks. Lung is not mature. For example, 32 weeks she has come. Lung is not mature. Can you take the baby out? You are worried because the lung is not mature. So what do? The resuscitation itself is the answer. You give her rest, sedation, arrange for IV fluids and keep blood ready, keep her in a high risk ward, bleeding stops in 90% of patients. Yes, that is what is known as the McAfee-Johnson. That is known as the McAfee-Johnson regime. This name came in a NEET exam once. McAfee-Johnson. This is conservative management. Bleeding stops. Bleed stops in 90% patients. Yes. So that is what is the management. Rest, sedation, steroids, 10% patient the bleeding will not stop. So that becomes the contraindication for this conservative management, that the maternal instability, bleeding continues, or the baby is dead, or the baby is having anomalies and patient is in active labor. All of these are conditions where you cannot do the conservation. So conservative management stops the bleeding in 90% of patients. You send the patient to the ward after 24 hours if the bleeding has stopped, and she'll be in the ward for one more day and then she can actually go home. But if the bleeding continues and if the baby is dead and anomalous, there's no way that you will continue the pregnancy. Then you'll have to do a cesarean section. So contraindication to conservative management, this becomes the NEET exam question. Yes, this has come. Where will you not do conservative management? So conservative management has a place in your exams. Please remember that. Abruptio placenta, also known as accidental hemorrhage. This is associated with painful bleeding, and this is the most common APH. The most common antepartum hemorrhage is abruptio placentae, 1 in 200 pregnancies, associated with hypertension, high blood pressure. This is the classical MCQ, classical, they'll give you clinical situation in your exams. They'll say 170 by 100 is the blood pressure and painful bleeding at term. This is the language which will come in the exam. So fatafat make your diagnosis, it's an abruption. Okay, mostly it's an abruption. It can be so many other things in obstetrics, but we know that we're going to ask you core basics. So painful bleeding at term with hypertension, think of abruption. Now this abruption can happen in smokers and drug addicts, elderly gravidas, multiparous women. Multiparous means more than second delivery onwards, premature rupture of membranes, chorioamnionitis, infection in the uterus, previous abruption, thrombophilias, twins. Yesterday we had a long discussion where my students asked you. So if you see the mission FMG yesterday. Please go and see thrombophilias towards the end of the, I've said thanks and then I've taught thrombophilia. So please go to the video mission FMG thrombophilias. I've taught you there. Okay, today we'll just avoid that discussion. Then in twins gestation, external cephalic version, ECVS, external cephalic version, turning the baby a breech to cephalic, turning a transverse light to cephalic before delivery, and circumvallate placenta. So all of this can cause abruption. So main cause of abruption, for theory you can remember all of that, but for practical and all exam questions, abruption is hypertension associated. So presentation of an abruption, what happens? Now this is what you have to know. The main part of the chapter is to understand this picture, that when a woman has a placenta in the upper segment, but the placenta has separated, that is what is abruption. We say accidental hemorrhage. The placenta separates before delivery. So placental separation, that is what is abruption. Placental separation before delivery. Placenta should separate only after delivery, but if it separates before delivery, then that's a major problem. So yes, when it separates, they will have the blood getting accumulated here. So it could be a concealed bleed. It can be a concealed bleed, or the blood can come out like this. It can be a revealed bleed, or they can be bleeding into the uterine muscle, bleeding and bruising into the uterine muscle, or a bruised uterus. That is known as a covular uterus. Covular uterus. This is what is a very common MCQ. Where do you see a covular uterus? You see a covular uterus in a abruption. So concealed bleed, revealed bleed, and covular uterus. Now this bruising, that is why when you touch the uterine muscle, it is tender, painful bleeding. You keep reading painful bleeding, painful bleeding, painful bleeding. Kyun ho raha bhai? Because the uterine muscle is having bruises. If you fall on your hand and if you have a bruise, don't you think it is painful when you touch it? Similarly, this is what is the problem here. This is what is a patient having a bruising on the uterine surface, and that is tender. So painful bleeding. Okay, painful bleeding is the reason because of this bruised uterus. Okay, remember one thing, the background music which is running in your head when you see a case of abruption, blood clot, eats up coagulation factors, and DIC can happen. So that DIC is that background music. Yes, always think that DIC can happen in a patient with abruption, and that's why abruption management is to be way more smarter. Yes, patient can go into DIC. Like there's always a background music, right? When you're crossing a road, you may get an accident. When you're going for an exam, you may fail. So that is the background music which is there in your head whenever you're doing something. So when you see a case of abruption, yaar, DIC na ho jaye. Okay, keep that in mind, then the management options will be easier to understand. So presentation of abruption, painful bleeding due to the bruising of the uterine muscle. Uterine height will be more than the period of gestation. Uterus will be a little higher because of blood clot, and tense and tender abdomen on palpation. So when this uterine muscle is bruised, it does not contract so effectively. So the labor is a little delayed. Labor is protracted, delayed. But yes, sometimes it happens in a hurry also, abruption. So labor will happen in abruption definitely, but it may not start very effectively. So labor is protracted, and moment the baby delivers, after that also the contraction won't be very nice because the uterine muscle is bruised. So when the uterine muscle is bruised, it does not contract for delivery of the baby. Once the delivery happens, it does not contract, and when it does not contract after the delivery, atonic uterus can cause PPH. Yes, so the same abruption which causes antepartum hemorrhage, and because of the bad bruised muscles, they can also have postpartum hemorrhage. All right, so if this labor is protracted, and PPH chances are more in a case of abruption. What is the management of abruption? Yes, a patient has come with hypertension, reduce the hypertension, give a rest and sedation. But what do you do with abruption? You will do a normal delivery or a cesarean. So, abruption at term 37 weeks to 42 weeks, resuscitation and deliver. Correct? That's the answer. Abruption 37, 42, IV line, IV fluids, all that you can write in your theory exam. But what is the core basic? Resuscitate and deliver. This much you should know. How do you do resuscitation? It's taught to you in many subjects. You have to deliver. How do you deliver? You do a cesarean section. Yes? No, man. Cesarean is not the answer to abruption. Please. Abruption by itself is not an indication for cesarean section. So, you do a cesarean section only if there is a fetal distress, the fetal heart rate is less than 100, or if the fetal scalp blood pH you've done, it is showing acidosis. So scalp blood pH, baby का blood निकाल लेते हैं हम लोग vagina में से जाके, we make a small cut on the head of the baby, take that one drop of blood, small cut, and with the pH is less than 7.8, or there is fetal distress, then I do cesarean section. So indication of cesarean is not the abruption, it is the distress if it is there. If the baby is fine, we do normal delivery. So yes, delivery is by normal vaginal delivery. We deliver normally vaginal. Normal vaginal delivery is what is done. Very, very important. All right. So when we are doing this, how do? We do an ARM. Okay, remember that. This is the Cocker's forceps. This is going to come in your exams. Cocker's forceps, the instrument. So Cocker's forceps, if you look at this tip of this Cocker's forceps, it has got this two teeth on one side and one tooth on this side, and when you go and hold the membranes, it will give a very good grip, and when you pull it, it is going to tear the membrane. So go into the cervix, reach the membranes, hold them and pull them. So artificial rupture of membranes. So look at my hand again, you see this, when you're doing artificial rupture of membrane like this, the placenta is attached here. Oh, can you see now? Yeah, the placenta is attached here. So when you do the ARM, okay, see this, when you do the ARM, the ligature will go out and the uterus will contract. The ligature will go out and the uterus will contract. So this separated placenta will be compressed by the uterine muscles. So that's why the bleeding will reduce. Also, what happens? See this, when you do the rupture of membranes, this placenta here, can you see the placenta is here? The uterine muscle will compress the placenta against the body of the baby. So bleeding will reduce. Also, you've gone through the uterus cervix and you've irritated that area. So that is going to release prostaglandins. So that causes also induction of labor. So what is written here? For the normal delivery in abruption, what do? You do an artificial rupture of membranes. That induces labor because it releases local prostaglandins and also causes compression of placenta. That reduces the bleeding. All right. Plus, we can give a oxytocin drip. Give an oxytocin drip. That is also going to help in the delivery. All right. Now, that is abruption at term. If there is abruption happening before 34 weeks, just like Placenta previa I discussed, before 34 weeks, lung is not mature. Now, if there is abruption at 32 weeks, that is less than 34 weeks, and that is there is lung is immature. If the lung is immature, then what do you do about this? So, immature lung, that is before 32 weeks. Before 34, I'm just giving you example of 32 weeks. Don't get confused. Before 34 weeks, lung is immature. Both Placenta previa and abruption, I've given you example of 32 weeks. Okay, don't get confused. So when you're doing this, any patient with abruption, again when she comes, you'll have to do resuscitation, you'll have to give a rest and sedation. So 34 weeks and before lung is immature, she's bleeding at 32 weeks, you give her the resuscitation and steroids because you want the lung to get mature. Now what can you do about abruption? Can you do a normal delivery? Yes, I said you can do a cesarean if required. But can you wait like you waited in a case of an Placenta previa which was bleeding at 32 weeks? I said if a woman is bleeding with Placenta previa at 32 weeks, conservative management will stop the bleeding in 90% of cases. But that was Placenta previa. And Placenta previa is because the placenta separates with shearing and the bleeding stops in 90% of patients. This is the case of abruption and the background music is DIC can happen. So that's why if DIC can happen, that's why we say deliver. You will deliver. Do ARM and give oxytocin and deliver. No conservation. No conservation in a case of abruption. So when abruption comes at term, deliver. You do normal delivery. If there's a distress, you do cesarean section. Abruption comes before 34 weeks. The lung is not mature. You will give rest, you will give sedation, you will give steroids, but you'll do an ARM. Yes, you'll start oxytocin at the same time. She'll not deliver in 1 second like that. She's going to slowly increase the prostaglandins. Oxytocin is going to help in the starting of the labor, but she's going to deliver probably tomorrow morning. So you'll get some time for the steroids to have an action. So you will get some lung maturity. You may get at least 24 hours, sometimes even more. Keep her in the high risk ward, keep her in the highest supervision, and do a normal vaginal delivery. Yes, by the time she's delivering, if there's a distress, I'll do a cesarean also. Cesarean, because of distress, that's a separate thing. I'm planning delivery normally. But what I'm trying to say, if it is abruption before 34 weeks, do not say conservation. You say conservation only in placenta previa. Here, you have to deliver. Only thing separate from that patient who had abruption at term and the abruption before 34 weeks, only thing separate is the steroids. So, if there is an abruption at term, resuscitate, deliver. If it is before 34 weeks, resuscitate, steroid, and still deliver. So learn punchlines, guys. If you understand punchlines, then theory to koi bhi kabhi bhi likh sakta hai. Right, guys? So if you don't have any other questions, we are going to terminate this session. And I hope it was useful for you to understand the PPH at least. Placenta previa abruption were added topics for the day. I thought we must tell you a little bit more. Of course, abortions are discussed very well in your app. We can try and discuss abortions as a separate topic sometimes. But for exam, PPH. It's a major discussion. Right, guys? I'm not seeing all of you asking me many questions today. So as and when you get back, you can please send questions on the YouTube, the chat which is going on right now, or you can ask questions below that and just inform the team that there are some questions which we want to ask, sir. We will always be in touch. Please keep coming back for more. Thank you so much. Sorry for the odd delay today in the beginning of the class. There were some definite problems in all the networks which were there. So fortunately, it all got into shape. Thank you so much. Good evening.